Hello, I'm Dr. Marla Shapiro. I'm a past president of the North American Menopause Society, and I'm joined today by Dr. Cassandra Schufelt. She's an associate director at the Barbara Streisand Women's Heart Center and co-director of the Preventive and Rehabilitative Cardiac Center. She's the director of the Women's Hormone and Menopause Program and an associate professor at the Cedars-Sinai Medical Center Schmidt Heart Institute in Los Angeles, California, and she is NAM's president-elect. Cassandra, I don't know how you found time to join us today. You're so busy.
Of course, I make time for you, but thank you very much. That was a gracious introduction.
Okay, well, let's start with, it's leading cause of death in women. So let's start with the important stuff. As clinicians, how do we determine if a statin use is needed in women? And as physicians and healthcare practitioners treating women, how is it different than men? And what steps do we need to specifically look at when making this decision for women?
Yeah, so this is a fantastic area, and we have a great upcoming practice pearl that will be released that summarizes everything. It's been updated from the 2014 practice pearl that you can get on the NAMS website. But there's been a lot of change in statin initiation and statin therapy, and more specifically to women. We do know that there are 4 categories that are recommended carte blanche if you have a woman that falls into these categories. It also is if you have a man that falls into these categories. So while it's not sex specific for these recommendations by the American Heart Association, they are there are risk additions that are specific, which we'll get into for women specifically. So the 4 categories are if you have a woman who has established cardiovascular disease. So we know secondary prevention is very strong evidence for both men and women that the reduction is important not only for future risk of cardiovascular events. So if they already have established cardiovascular disease or have had an event itself. So that's number 1. Number 2 is if the LDL cholesterol, regardless of age, if the LDL cholesterol is over 190, and that's a fasting LDL. And that's probably more because it's a familial hyperlipidemia. So you can probably look back in their family history that they have a strong family history of genetics related to lipids. So that's a woman that you'd want to start statin on. The third group is a diabetics. So this is where it's a little different. We used to say a diabetic based on risk, but now it's regardless of what risk they fall into. It's if a woman has type 2 diabetes and is between the ages of 40 and 75, that's a woman that we want to start on a statin therapy. And then the 4th category is someone who we would consider a high risk person. And I'll delve into how we calculate that high risk, but that risk is greater than 20%. And if that patient's greater than 20% risk, we're using it now for primary prevention. And this is what's really interesting and new in the area of statin therapy. Now, if a woman is intermediate risk and they fall into it between 7.5% to 20%, and they have these things called risk enhancers, and these are where it's more specific to women.
Okay, so let's go there then next. So what are the unique risk factors in women that will make her at higher risk, those so-called enhancers, as you call them, where statin therapy might benefit?
Yeah, so risk enhancers are used really for this borderline risk or intermediate risk. So that's anywhere from a 5% using the risk calculator, the atherosclerosis risk calculator, or an intermediate risk up to 20%. So this really provides us additional information that we as providers can use to make shared decision-making with the patient. And risk enhancers that apply both to men and women, but they are specifically family history of cardiovascular disease and early cardiovascular disease. So basically, if you have a male relative, first degree relative less than 55 years of age, or a female relative less than 65 years of age, that's considered a family history of an early cardiovascular disease. If you have chronic kidney disease, metabolic syndrome, chronic inflammatory diseases, which are more common in women, we know that lupus, a lot of inflammatory conditions are coded on the X chromosome, so they're more common in women. Anything, there's also high ethnic groups such as South Asian ancestry, or if you have a fasting elevated triglycerides greater than 175, and that's, but risk enhancers that are specific to women, that are specific to the Menopause Society and our providers include premature menopause. So this is now we know that if you are entering menopause under the age of 40 years, that's an identified risk enhancer, as well
And
as adverse pregnancy outcomes. So
right.
history of preeclampsia. And although not well named in the guidelines, adverse pregnancy outcomes we know predict future cardiovascular events. So I wouldn't just stick to preeclampsia. I would also ask in your review of systems in your intake about gestational hypertension during pregnancy, even if they had small gestational age for the infant, preterm delivery, whether it was spontaneous or induced, should also be considered.
Okay, moving on to the concept of coronary calcium scores and coronary calcium scans, which are not necessarily available to everybody. But let's first talk about the role that they may play in determining therapy. And then, if you don't have that as an easy testing, what are there any other testing alternatives that we could consider?
Yeah. So right now, there was a lot of concern about radiation to the chest wall and to the chest area, specifically in women. And the use of coronary calcification scans or coronary artery scans will give you a score. And we now know that the radiation exposure is very minimal. So that's the good news. And so, and it's a very simple test, non-invasive, obviously. Sometimes have to pay out of pocket for it, but the cost is very minimal. So let's discuss what that is. It's a score of the coronary arteries itself, and a 0 is obviously no plaque itself, but it can go up to 100, over 300, and over 1,000, and it gives you a percentile. So after you consider the risk enhancers, if the decision remains unclear about whether or not to use a statin, or if your patient remains very reluctant to use a statin, the recommendation is really to consider coronary artery calcification scans. So if the calcium scan is 0, no statins indicated. So that's very encouraging and would let the woman know that no statin would be considered. If the calcium scan is between 1 and 99, then a statin is very much favored. But if the calcium score is greater than 100 or equal to 100, or if that percentile that I mentioned based on her age is greater than 75, greater than or equal to 75 percentile, that is where a statin is indicated. You bring up a really important point because not everybody has an access to the calcium scan itself. So there are additional biomarkers that are mentioned in the guidelines to calculate that ASCVD risk calculator, and they were added to include things like high sensitivity CRP. So if that's greater than or equal to 2, that can also be considered as one of these tiebreakers in terms of if the patient is really unclear or unwilling or reluctant to use it. Apolipoproteins greater than or equal to 30. And also if the LDL is greater than or equal to 160. So while the familial hyperlipidemia is greater than or equal to 190, this is where an indeterminate value of, you can look now specifically at the number. We were pulling away from looking at the actual numbers, but when you're looking at it itself for determining what to do, we can look at the LDL greater than or equal to 160.
So these are multipliers that would encourage you to move in one direction versus another.
Exactly. And they're helpful, I think, for really, instead of as a clinician just saying, here, take the statin, it then allows for a biomarker above and beyond this risk calculator to then explain to the patient, we really need to go forward and start the statin medication.
So now let's talk about statins, because so many people talk about their side effects. And many of them, we rely on the patient history. Is there a gender difference? Are statin side effects worse in women than in men?
Yeah, so this is also an important area because it really wasn't identified in clinical trials because women have been so underrepresented in clinical trials specifically for statin therapy. So if you look at primary prevention trials, women are generally about 20% of all of the primary prevention trials. So while we get a lot of information about side effects, we get a lot of information when you do clinical trials. And when you have underrepresentation, you also get underrepresented side effects. Specifically to women. Now, we do know women have more myalgias and more side effects related to taking the statin itself. And so that's number one. The other important thing to consider is that in some women, and as well as some men, statins can increase blood sugars or A1C. So you do want to get a baseline A1C and then monitor it after you start the statin therapy.
Okay. Now, for women who are reluctant, and there's so many people who read lots of things about statins in the newspapers and hear it on the media, and they may be really reluctant to get onto a statin therapy without necessarily recognizing the benefit that it may give you. So, what are some pearls that you might give us when we have someone where we clearly feel that this is beneficial and we really do want to start this for risk reduction, but we have someone who's a little reticent?
Yes, and if you look at the guidelines, they really started talking about a moderate to intense statin therapy, which you're looking at doses that are on the upper end. And when you start talking about a 40 milligram dose of atorvastatin or a 40 milligram dose of rosuvastatin, that might sound a little bit overwhelming to a lot of women, especially as we all anecdotally hear in our practice, I'm very sensitive to medications, doctor.
Right.
And that probably is something that's very true related, as we know, and not just anecdotal, because women do metabolize medications much differently than men. And unfortunately, we only have one drug out there that has a dose for a man and a dose for a woman, and it's not a statin. So clinically, there are differences in statins. So meaning the way it's metabolized in the liver, you also want to make sure that you look at polypharmacy because a lot of medication can metabolize through the same pathway in the liver. But anecdotally, one of the things that you can do is dose it more infrequent and then titrate it up. For example, you could start with a lower dose of rosuvastatin and dose it perhaps twice weekly for a few weeks, and then continue dosing it up to 2 to 3 times. That's one of our protocols here in the Women's Heart Center. There are statins that are more water soluble versus lipid soluble. And specifically, rosuvastatin is one that has more or less side effects in women in terms of the myalgia.
And before I let you go, often, people will think the lowest dose is really what's best. And I'm not sure where the bias comes from in our patient population, but many will ask you to start something as low as 5 milligrams rosuvastatin. And if you see that on 5 milligrams, you're close to target for that LDL. Is that enough, or do we need to push the dose up to get more of an anti-inflammatory effect on the endothelium? Any information as far as that's concerned?
Yeah, so we're not saying as low as we are now not concerned about how low you can go. We do want the LDL very low, and specifically the previous guidelines were saying less than 70, and now we're even pushing LDLs into the 20s and 30s, and we have that data to support it from the PCSK9 inhibitors in terms of those clinical trials where you get those very low values. But I would say that if you do have a woman who's on a statin and is able to tolerate it, and you get the LDL down below and at a very low level, then that would be appropriate to stay on that current dose. There's no reason to then jump from a 5 milligrams up to a 40 milligrams of rosuvastatin, for, let's say, if the LDL is very low already.
All right.
And you can look at some of those biomarkers as well in terms of what they are doing for inflammation.
So much to think about, but so important because it still remains our number one leading cause of death, despite often women not being aware.
Exactly.
Thank you
Well,
so much for joining us today.
thank you for having me.